Good evening, everyone, and welcome to today's session. Bhargav, Ajay Mukherjee, Nagambika, Nishant, Gokul, Yoganand, Praveen, Farha, Anjum, and many more who are all across the country. This is Dr. Murli Bharadwaj, your classmate in everyday preparation for MBBS exams, whether it is practicals, whether it is theory, FMGE, NEET PG, AIMS, PGI, any of the PG medical entrance, USMLE or any licensure exam, you can count on me. I'm very much there with you to study with you every day and spend a good amount of time with you to unravel the concepts, make them easier, clearer, so that you are ready for the exam. So, thank you all for joining this evening. Some of you have finished your final MBBS last exam today, if you are from Telangana or Andhra Pradesh. And some of you are exam going, whatever it is. Practical exam of the final year is always a tough and also easy. If you learn the concept, it's easy. It's a smart preparation which is required in order to crack the examiner's expectations. So let us become expert in what are the common clinical cases, common clinical examination, and the viva voce questions which are asked by the examiner. So let us start with the clinical cardiology, and we'll move also into clinical neurology and make a good beginning today, right? So can the online students can punch whether the voice is loud and clear? And thanks to all of you for joining our final MBBS exam going telegram group. Final MBBS exam going telegram group. You can also tell your friends to join. And the beauty part is anywhere you can sit, anywhere teacher can sit. Even in the midnight also we can sit and have a discussion. Early morning we can have a discussion seamlessly, interactively. So let's make the great beginning, doctor. So how do you examine pulse? Examiner's fundamental question in the undergraduate exam. Now, you can feel carotid, radial, femoral, brachial. So basically the heart is pumping the blood and that is leading to a rise of the pressure in the pulse, in the periphery. So if you take cardiac systole and the moment you see the pulse, in the case of the carotid, it is very close to the heart. It is only 30 milliseconds. Radial is 80 milliseconds. Brachial is 60 milliseconds. And femoral is 75 milliseconds. Now, what are all the locations where you look for the pulse? One of the most important things as an undergraduate MBBS student is always look for the pulse in all the four limbs. On the bedside, whenever we examine the patient, we only check the pulse on one side and ignore and move forward. No. Examiner will observe, are you examining all the four limbs for the pulses or not, is very, very important. So what are the areas where you look for the pulse, doctor? Radials, brachials, carotids, femorals, popliteals, temporal, facial, dorsalis pedis and posterior tibial. Very, very important. Why these peripheral pulses are required? If the patient is having a significant amount of atherosclerosis, or some people have thromboangiitis obliterans, who are smokers. Typically, the peripheral pulses examination is very important in them because they are suffering from ischemia. because of thromboangiitis obliterans. So that is the reason. What are the two important points you are going to remember, doctor? Examine all four limbs. Examine all the vessels for the pulse in the tomorrow's bedside examination. So how to feel the pulse? If it is radial pulse, the three middle fingers are used on the palmar surface, and where is radial? Radial is more towards thumb or little finger? Thumb, right? So towards the radial side, against the radius, which is the bony background, you can be able to feel the radial pulse. Then how do you examine and where do you examine for carotids? The patient will be lying down with the head, with the bed elevated. So if this is the head, then the bed is elevated at 30 degrees if you want to examine the carotid. Is carotid medial or lateral to the sternocleidomastoid? Very important. It is just medial to the, the sternocleidomastoid, no, it is medial to the sternocleidomastoid is what you should remember. And you place your left thumb on the right carotid of the patient. Your left thumb on the right carotid of the patient, where in the lower third of the neck is the place. In the lower third of the neck is the place at the level of the cricoid cartilage. You should look for the carotid pulse. What is an important principle, doctor? Don't examine both the pulses same time. If you do that, patient goes to heaven. Why are we called God's messengers? Because in our hands, a lot of patients will die while we are learning the clinical medicine, right? Never examine both the pulses same time. Examiner will be disappointed if you are examining both the pulses at the same time. Carotids. Only one carotid at a time. Lower one third of the neck, medial to the sternocleidomastoid is what you have to basically remember. So your sternocleidomastoid is there, medial to the sternocleidomastoid, lower one third of the neck is the location where you basically need to examine for the pulse, carotid pulse. Then how about the brachial artery? So brachial artery pulsations very commonly used. So use the thumb of the opposite hand. That means if you are examining the right hand of the patient, the examiner's left hand has to be used. You are examining the patient's left hand, brachial pulse, your right hand should be examining. That is very important. And where do you feel? You have the biceps tendon. So it is just, first feel that biceps tendon. It is just medial to the biceps tendon. You find the brachial pulse. Then where do you find femoral pulse, doctor? How to examine femoral pulse? Anterior superior iliac spine, a very prominent part of that bony here, anterior iliac spine, superior iliac spine. And symphysis pubis. So typically it is midway between the two. You need to identify these two bony landmarks. In the midway, you need to basically feel for the femoral pulse is what you have to basically remember. That's right. Very good to see Mohan Babu joining this session. Very good. So doctor, some points that come to your mind, right? This is a very interactive session. I want you to talk, I want you to laugh, I want you to interact, ask questions, answer questions. Because in a big crowded classroom, it is very difficult to be interactive. There is on YouTube, you're all on the messaging. So that is the reason, please be interactive, answer the questions and enjoy the session. Learning is supposed to be a big fun, right? And most important, go back to the hospital tomorrow along with your classmate. Nobody will teach. You have to learn, that's all. Nobody will teach. You have to learn. You have the patients lying down. You do a rehearsal on examining the carotid, examining the brachial, radial, etc., etc. And once you do this clinical examination on about 20 patients, 30 patients, even tomorrow's exam hall also, automatically you will be examining everything and then your presentation become much more robust. Right, doc? So, popliteal pulse. So, how do you feel? Encircle your fingers behind the knee, and here you will feel in the midline the presence of popliteal pulse. Then dorsalis pedis, very commonly examined in the clinical examination. So, how do you feel the dorsalis pedis? You need to feel the dorsum of the foot just lateral to the extensor tendon of the big toe. The big toe is having an extensor tendon, no? Just lateral to that, you have to feel the dorsalis pedis. And see, this is you can see here, extensor tendon of the big toe. And you need to basically feel just lateral to that, the dorsalis pedis is what you have to remember. Then posterior tibial. How do you examine posterior tibial? You need to curve your fingers behind and below the medial malleolus of the ankle. This is the medial malleolus. Behind iska piche hai, behind. And below the medial malleolus is the location for feeling the posterior tibial artery is what you need to remember. See, doctor, for you it is once in a lifetime opportunity to go for the MBBS final exam practicals. For the examiner, it is a everyday affair. The way you are examining only, he will be able to know that have you earlier examined a lot of patients or you are first time examining. He will be very easily able to know it. So that is the reason you need to be very professional. You need to have a complete anatomical knowledge on what you are doing, what are the routines to be done in the clinical examination and the clinical presentation. That is the whole purpose of our session. So doctor, this is the medial malleolus. This is the posterior tibial behind the medial malleolus. Now what do you examine in the pulse, doctor? Rate, rhythm, volume, force, tension, and comparison on two sides. Any special character? How is the condition of arterial wall? Force is different from volume. Force is different from volume. Volume means it is the amplitude of that pulse. Force is with which it is hitting your fingers, examining fingers. So there is a difference between the two. Agreed? Now, why do you need to compare two sides, doctor? Is it possible that you have a young, sweet-looking Asian female presenting with hypertension? One side she has pulse, another side she does not have the pulse. That is the reason you need to compare two sides. So can you tell me what is the diagnosis of this young, sweet-looking female, Asian girl, Asian lady, presenting with hypertension? One side you are able to feel the pulse, other side you are unable to feel the pulse. Can anybody give me what is the most common diagnosis in that situation? Come on, whoever answers the question will get gold medal. Very good. Deepak, Madhusudan and Ajay Mukherjee. Excellent, doctor. Takayasu arteritis. What is Takayasu arteritis? It is aortoarteritis. That is, arch of aorta is suffering from a vasculitis. And what arises from the arch of aorta? Subclavian. So typically when the arch of aorta is having vasculitis and that led to stenosis of the subclavian, and there is a decreased blood flow through the subclavian, that makes that side, typically on the left side, it become pulseless. That is the reason Takayasu's aortoarteritis is called pulseless disease, is what you need to remember. So today, pediatrics final exam is over in Telangana. So I was just talking to one of the students. So I came to know that today Kawasaki disease is given as the long question. Treatment management of Kawasaki. I'm so happy. A lot of our students who enroll in our video library, we have about 300 hours of video lectures in medicine, surgery, gynops, orthopedics, pediatrics in the final year in the online MBBS.com video library, along with the notes covering most of the common stock topics in the exam. So those who have joined our video library last 1 year and have listened the videos, I'm so happy to listen from them that sir, today paper was like a cakewalk. So many things that we have discussed. We didn't even read the book. We only reviewed the videos and are able to crack the exam, the final MBBS exam. Very good. So I'm very happy to listen that. So we have another 15 days before the practical exam. So I thought some of the common long cases, short cases, let us take up for a discussion to give the final touch so that you should aspire for getting a gold medal and distinction score in the final MBBS exam. So doctor, what is the normal rate? 60 to 90 beats. And how long you need to count? If it is regular, you need to count in 15 seconds into 4. If it is very fast, tachy, if it is more than 100. If it is less than 60, you call it as brady. If it is brady, then you need to count for 1 minute. So you need to count longer if there is a bradycardia. And if it is tachy, even if you count lesser time, still you can be able to make out the count. But still, it's a good practice to count for 1 minute. Then apex pulse deficit. What is the meaning of it? So typically you are having, let us say, atrial fibrillation. Atrial fibrillation. What happens? John Kefa says Kawasaki disease is the essay today. Yes. The mucocutaneous lymphadenitis of Kawasaki, where there is a coronary vasculitis in a pediatric age population. Very interesting question. So now, doctor, if there is an atrial fibrillation, what's happening? The atrium is weakly pulsating, right? And that is decreasing the preload to the heart. Because unless atrium is strong enough, it can't be able to push the blood into the ventricle. So it is weakly pushing the blood into ventricle. That's the reason the pulse, every time there is a cardiac output, it is not translating into a pulse wave. So the pulse wave will be lesser. The pulse you calculated will be lesser, but the heart rate will be same. The heart rate is same when you auscultated the heart. So this deficit called apex pulse deficit means to say that there is an atrial fibrillation. That's the reason every time the cardiac output is bursting into the aorta, it is not translating. It is not strongly enough pushed into the aorta that it is not translating into a pulse. So apex pulse deficit is an indication of atrial fibrillation. How much? If the difference is more than 10, that means you calculated 70 beats in the apex, but pulse is only 60 beats. So more than 10 is suggestive of atrial fibrillation is what you should remember. Then how about the rhythm? Is it regular? Sa, re, ga, ma, pa, da, ni, sa. So, is it regular? Or is there any phasic irregularity whenever the person is taking respiration? So, typically, what happens during respiration, doctor? What happens during respiration? There are two phases of respiration. One is called inspiration, very good. Other is expiration. So, whenever you are inspiring air, what's happening? There is a negative intrathoracic pressure. Negative intrathoracic pressure. Whenever you are having inspiration. Agreed? So that negative intrathoracic pressure, what will it do? It will suck the blood. It will suck the blood from the great veins and pours it into the heart. So all the great veins drain into which part of the heart? Right side of the heart. So the right side of the heart will have more amount of the blood, right atrium and right ventricle. That will make the interventricular septum to twist into the left side. So that is the reason what happened. The left side volume has become encroached by the right side encroaches into left side. So from the left side, the blood which is being pushed into the aorta will decrease. And because of that, what will happen? The pulse become weaker. Normally only pulse is weaker during inspiration and it is relatively more stronger in the expiration. This kind of a change in the pulse is basically called sinus arrhythmia. That is, with respiration it is changing. So that is what is a normal finding. Then, if it is irregular, if the pulse is irregular, sa, re, gagama, sa, re, gagama. So, instead of sarigama, it is becoming gagama. Then what is the underlying cause? If it is regularly irregular, sa, re, gagama, sa, re, gagama. Then, if it is regularly irregular. Whereas if it is irregularly irregular, sa, sa, re, 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 sa, 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 re, sa, sa, re, sa, sa, re, re, ga, ga. So, it is irregularly irregular. If it is regularly irregular, what is the cause? Atrial flutter, paroxysmal atrial tachycardia, they are the underlying cause. But if it is irregularly irregular, then it is atrial fibrillation, ventricular premature complexes, they are the underlying cause. But let me tell you, these are all theory discussion. It's not that patient examiner tomorrow in the final MBBS exam, they will put one irregularly irregular and check whether you will be able to find it or not. No, it's not like that. But examiner, when the discussion for the pulse comes, will start ripping you on each of these points. So you should be very sure at least to give one cause for each of these scenarios. Tell me now, regularly irregular. Where do you find, doctor? Paroxysmal atrial tachycardia or atrial flutter. Irregularly irregular, ventricular premature complexes and atrial fibrillation. They are the two scenarios that you need to remember. If you still have time, Manish is asking, sir, this video will be in YouTube, right? Oh yeah, definitely. Why not? Why not? Knowledge is supposed to be free, affordable, accessible anywhere, anytime, doctor. We strongly believe that. I'm really so happy to see 80 online MBBS final year examination completed students. So, going for the practical exam shortly. A wonderful opportunity. So definitely we will keep the video. But just tell your classmates and friends that, hey guys, final MBBS exam going Telegram group. Ask them to join and you can tell your juniors also to join that who are finishing their ENT optal exam, and they can also subscribe in the online MBBS.com video library, where you have 300 hours of video lecture covering theory in medicine, surgery, gynocs, orthopedics and pediatrics, which is going to help you to quickly do the revision. Now, doctor, amplitude. There are two types of pulses. One is called hyperdynamic, other is called hypovolemic. Hyperdynamic. When will hyperdynamic occur? You all know cardiac output. What is meant by cardiac output? Every time heart is beating, it is pushing almost half liter of, it is pushing around 500 ml, and whatever the cardiac output is there, that is cardiac output. Second, you know the concept called total peripheral resistance, doctor? If the blood vessels vasodilate, then the peripheral resistance will fall. If the blood vessels vasoconstrict, then total peripheral resistance is high. So what happens if the total peripheral resistance falls down? What will happen if the total peripheral resistance fall down? If the total peripheral resistance fall down, the heart has pumped the blood very easily into the aorta, and since there is no resistance, resistance is low, it quickly finished the circulation and came back to the heart quickly. So circulatory time become decreased if the resistance to the flow happens to fall down. So a fall of TPR decreases the circulatory time and make the heart to increase its rate, right? So in that situation, wherever the total peripheral resistance is low, because the peripheral vasodilation with a low circulatory time, that lead to hyperdynamic circulation. So anything that speeds up the heart is hyperdynamic. Anxiety, exercise, it speeds up. Aortic regurgitation, fever, anemia, thyrotoxicosis, arteriovenous fistulas, beriberi. These are the classical example of hyperdynamic situation, hyperdynamic circulation. Examiner will ask, hey Raju, hyperdynamic circulation ka 5 reasons bolo. That's what examiner is going to ask you in the Viva course. Like a parrot, you should answer. Anxiety, exercise, AR, fever, beriberi, anemia, thyrotoxicosis, pregnancy. They're all hyperdynamic circulation should be your answer, right? So any increased cardiac output, obviously if the circulatory time decreased, what happens? The blood is quickly returning to the heart. So that is the reason the cardiac output, stroke volume also will increase. So now tell me, what is hyperdynamic circulation? It is a state of high stroke volume, low TPR, total peripheral resistance, and decreased circulatory time. This is what you need to remember. Then what are the reasons where pulse is not hyperdynamic? Like Shatabdi Express, tuck, 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 tuck. It is not like that. It is like tuck, 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 tuck. It is hypovolemic. In what are the situations? If there is any shock, congestive heart failure, hypovolemia, any aortic stenosis. Stenosis is a hypovolemic state. And any cardiomyopathy. In all that, typically it will be of a low stroke volume, opposite to what happens with the hyperdynamic circulation. Vaibhav is asking, what is CHB? CHB is complete heart block. Complete heart block. Right? Now, let us talk about the force and tension. What is the meaning of force? It indicates systolic BP. So, increased systolic BP, as in the case of hyperdynamic condition, patent ductus arteriosus, aortic regurgitation, right? That will lead to a increased systolic BP and increased force, whereas shock, cardiac failure, stenotic valvular lesions, cardiac tamponade, in all these the stroke volume decreases and that lead to development of decreased force. That's what you should remember. So, very good to see Vijay, Bhargava and many more who are all online. Good. Then what is tension? Tension indicates diastolic BP, force indicates systolic BP. That's very important. Now, you need to invariably examine pulses on both the sides. Like a robot, whenever you are clinically examining a patient, like a robot, you should make a practice. Involuntarily, your hand should go to check all the pulses and both the sides. So, what are the causes of unequal pulse? Any embolus, erythematous plaque, or Takayasu arteritis lead to unequal pulses and pulselessness. Now, how do you draw the graph of the pulse? There is a systolic phase, diastolic phase. There is an ejected wave, reflected wave. So the moment the blood is pushed from the ventricle into the aorta, that lead to a ejected wave and rise of the pulse, and typically there is a reflected wave as a blood is moving forward. So in this reflected wave, typically there is a dicrotic notch, which is normally a normal finding, right? So this is the systolic peak and this is a dicrotic notch which is normally present. So what is meant by anacrotic pulse and what is meant by dicrotic pulse? Anacrotic means there is a slow rise instead of a sharp rise and a slow fall. That is called anacrotic pulse. And the duration of the pulse is typically prolonged, amplitude becomes smaller, and it is very lazy in character. Slow to rise, slow to fall, and that is characteristic of aortic stenosis. It is very easy to understand. There is aortic valve between left ventricle and aorta. So if there is any stenosis, when the ventricle is pumping the blood into the aorta, it has to push the blood against a small hole of aortic valve, which is stenosed. That will make the pressure to slowly rise and slowly fall, amplitude decrease, and the duration of the pulse increase, which is called pulsus et tardus. Pulsus et tardus, which is anacrotic pulse, which is seen in aortic stenosis. That is what you have to emphatically remember. Then comes the dicrotic pulse. Dicrotic means there is one peak in systole. Generally, there is only one peak in systole, but there is another peak in diastole. Two peaks are there. So where do you find two peaks in the pulse? If there is any myocardial disease, Akhilesh Jha is asking a very good question. Sir, how do we justify tension as diastolic blood pressure? Tension as diastolic blood pressure. See, doc, what is fundamentally systolic and diastolic blood pressures? When the heart is getting filled, right? The pressure that you are feeling is diastolic. It depends on what? The compliance of the heart. That means the stretchability of the heart. Then, and also on what? The volume of the preload which is coming to the heart. They are the determinants of the diastolic blood pressure. Then systolic BP is, it is the stretchability of the aorta, how stretchable it is. So that is the reason as we have discussed earlier, the force and tension. Force is dependent on the systolic BP, that is the stretchability of the peripheral blood vessels, the blood vessel as such. Whereas tension is a factor which is dependent upon the compliance of the ventricle and the preload that it is receiving. So that is the logic. So doctor, dicrotic pulse means one peak in systole, one peak in diastole. So in myocardial disease, when there is a reduced cardiac output, we find two peaks. Any left ventricular failure, two peaks. Dilated cardiomyopathy, two peaks. Any dehydration, two peaks. So two peaks fundamentally is suggestive of a low volume state is what you have to remember. So this is a normal pulse, and what do you find here? Anacrotic pulse. Hyperdynamic, increased in amplitude. Pulsus at tardus, and anacrotic means delayed rise, delayed fall. Then pulsus alternates, one beat strong, one beat weak, one beat strong, one beat weak. It typically is a classical feature of congestive heart failure. So just you need to walk into the clinic. Very good question. Manju, carotid is not felt against any bone, right? Radial is felt against the bone. Dorsalis pedis is felt against the bone. And femoral also is felt against the bone. Popliteal also is felt against the bone, tibia. So they are all felt against the bone, right? Now, Bhupendra is asking, what is the reason in cardiac tamponade? Cardiac tamponade, why do we get two pulses? Very good question. Fundamentally, what is cardiac tamponade, doctor? There is a lot of fluid around the heart, right? And what is this fluid basically doing? Normally, during diastole, the ventricle is supposed to receive the blood from atria. So, because of this fluid compressing the ventricle will undergo a collapse during diastole. That is called diastolic collapse of ventricle. Diastolic collapse of ventricle is the hallmark of the cardiac tamponade. So obviously when there is a diastolic collapse of the ventricle, it is unable to fill during diastole. So that is going to affect the cardiac output from the heart. So that is the reason, if you look at all these conditions which are leading to dicrotic pulse, what is the common denominator in all of them? All of them are the states of a decreased cardiac output. So that is the reason cardiac tamponade also lead to one peak in systole, one peak in diastole is what you have to remember. So doctor, pulsus alternans, where do you find? In congestive heart failure. Very good. Vijay Bhargava is giving a very good compliment. Sir, I got 90% in orthopedics. I am ready to have a good fracture, confidently to make myself available for Vijay Bhargava to operate me tomorrow, right? Your classes helped a lot. More than the classes, doctor, you are able to get inspired, to read a book, to listen a video. Sometimes it's lethargic. What is most interesting is live online interactive sessions. I always enjoy delivering that to you guys. And even at midnight also, because of the internet and YouTube, thanks to them, we are able to connect on the midnight also. Generally, most of the medical students, we are much more available after 8 p.m. morning, college, and so many avocations are there. So So that is the reason all our interactive sessions post 8 p.m. So that is the reason, please, please be part of our Telegram group. And since now you are finishing final year exams, you can join our Telegram group of NEET PG exam going. Now you are final MBBS exam going. So we are starting 4 groups. First MBBS, second MBBS, third, final exam going. Right? And NEET PG exam going. So 5 groups. Also one group called Survival of Internship Telegram group. See, internship, there are so many things like you should be part of a group which every day discuss a lot of clinical cases that they see in the hospital. So if you are part of that, what happens is all your intellectual curiosity will be very high and you will be really motivated to work in the hospital as an intern. And intern is the most beautiful time. You have to do your lumbar puncture. You can't miss it. You can't say, I'm preparing for PG entrance. I want to decay myself sitting in the reading room and library. No. You have to do lumbar puncture. You have to put Foley catheter. You have to do venesection. You have to do episiotomy. Everything you should be in the front foot. You have to put sutures, removal of sutures, writing discharge summaries. It should be dynamic. You should go and formalize a patient who had MI. If not in internship, when else in the life you can be able to learn. So that is the reason you need to fully use your internship. And let me vouch for you all guys that a good internship, a proactively, motivatedly done internship is a blessing in disguise when you go for the NEET PG or any of the medical licensure exam, USMLE or any exam, right? So that is the deal. So doctor, normal, hyperdynamic, pulsus tardus and pulsus alternans, you are very sure. So these are the normal pulses, these are the small and weak pulses of the tardus, large bounding pulses of a hyperdynamic circulation, and these are called Bisferiens pulse. This is called pulsus alternans. Now Bisferiens pulse and dicrotic pulse. What is common between both of them? What is the difference between both of them? Yes. What is common between them? What is difference between them? Bisferiens also has 2 peaks in the pulse. And the dicrotic also has 2 peaks in the pulse. But the difference is dicrotic has 1 peak in systole, other in diastole. Whereas both the peaks are during the systole only in case of Bisferiens. Both the peaks are during systole only in case of Bisferiens pulse. Now let us talk about Bisferiens pulse. Where do you find it? Hypertrophic obstructive cardiomyopathy is the cause for the Bisferiens pulse. Now let us discuss about it. What is hypertrophic obstructive cardiomyopathy? The interventricular septum is significantly enlarged in case of HOCM, hypertrophic obstructive cardiomyopathy. Now I am trying to explain why Bisferiens pulse with 2 peaks during systole in the pulse. Why does it happen in case of HOCM? Now we are discussing that. Now, typically aorta arises from the ventricle, left ventricle. Agree? Left ventricle. So from the left ventricle, when the blood goes into the aorta, what is that called? Left ventricular outflow tract. LVOT is the name given. Okay. Now between atria, left atrium, left ventricle, what do you have? Mitral valve. Okay. I'll do one thing. I'll try to Uh, yeah, I'll try to take a completely new slide uh, so that we have sufficient space to discuss this concept. Right, Doc? Yeah. Now, let's discuss about the HOCM. So, you are having the heart, interventricular septum is significantly enlarged. From the left ventricle, blood is going into aorta, and this is called as, what is this called? LVOT, left ventricular outflow tract. Now, from the left atrium, into the left ventricle, the blood is flowing through what? The mitral valve. Through the mitral valve. Yeah. So, this mitral valve has two leaflets. Anterior mitral leaflet and posterior mitral leaflet. Anterior mitral leaflet and posterior mitral leaflet. Yeah. So, this anterior mitral leaflet comes and touches this interventricular septum, which is hypertrophy. So, what will that lead to? That lead to an obstruction to the flow of the blood into the aorta through the LVOT, through the left ventricular outflow tract. Why? Because when the ventricle is undergoing systole, this the anterior mitral leaflet is touching the hypertrophied interventricular septum, and because of that, the flow of the blood into the aorta from the left ventricle become obstructed. But what type of obstruction is this? It is a dynamic obstruction. That means what will happen? The ventricle will strongly contract, blow it open, and then once more pushes the blood. So whenever HOCM is there are two systoles occur. One during this, two times the blood get ejected during systole. One, normally the blood is ejected from the left ventricle into the aorta. A little blood has moved from the left ventricle into aorta. The left ventricle size became smaller, and that will make the touching between the interventricular septum and the anterior mitral leaflet touching to happen. That will stop the blood flow. Then the ventricle will get some extra force and strongly contract, open that touching leaflet, and once more pushes the blood. So दो बार push होता है, just like एक theory exam और एक practical. So theory exam, first left ventricle pumped a little blood, its size became smaller, touching happened between interventricular septum and anterior mitral leaflet, that decreased the blood flow, that stopped the blood flow. But already initially some blood has flown, no? So you get one peak. Then the left ventricle strongly contracted and opened this touching obstruction and then pushes the blood. Once more the blood is pushed. So two peaks occur during the systole is what you need to remember. Amrita is asking, sir, can you please tell how long is this video? Maybe another half an hour, 15 to 20 minutes, no worries. I know that some of you are really tired of your pediatrics exam. No worries. So I will just, 1 minute, doctor, I will restart the video. I will restart the broadcast. Stay online. Very good. Welcome back, doctor. Sorry, there was a short interruption. So, there are typically two peaks that occur during systole if there is a hypertrophic obstructive cardiomyopathy and when the left ventricle is undergoing contraction during systole, when the blood is moved into the aorta, that makes the left ventricle size become smaller, and both of them there is a touching and obstruction and stoppage of the flow. So that is the reason after the first peak, the blood flow stopped into the aorta. Then once more the left ventricle with extra contraction will once more push the blood into the aorta and the second peak will occur. So this is called Bisferiens, is what you need to remember. Then finally, doctor, collapsing pulse or water hammer pulse. इसी को कहते हैं Corrigan's pulse, bounding pulse. So what is the story of these various kinds of pulses? I mean, all of them are the same name. Very simple. If you feel the pulse, suddenly raise the hand of the patient, the pulse collapses. You feel the pulse, raise the hand of the patient, pulse collapses. That is called collapsing pulse. A collapsing pulse is typically rapid upstroke, rapid downstroke. It has a high amplitude, short duration. And what is the cause for this? Aortic incompetence, patent ductus arteriosus, any hyperdynamic circulation like fever, anemia, thyrotoxicosis, pregnancy, AV fistula, where the circulating time is very short. Circulatory time is short with a low TPR. That lead to development of a collapsing or a water hammer pulse is what you need to remember. The rapid upstroke is because of increased stroke volume. So typically in aortic regurgitation, what is happening, doctor? If there is aortic regurgitation, the left ventricle is pushing the blood into the aorta, then the aortic valve closed, systole is over, and the ventricle is undergoing diastole and receiving blood from the left atrium. During that time, regurgitation occurs. So it gets its regular preload, and this regurgitant blood together, too much of blood is accumulating, and all that blood is pumped in the next systole. So that is the reason what is happening. Because of that, there is an increased stroke volume. And that is the situation where any hyperdynamic state, you find collapsing or a water hammer pulse. The rapid upstroke is because of increased stroke volume. That's what you should remember. Then what is the reason for a rapid downstroke? Why the pulse which rises very sharply, suddenly why does it fall down? Because after the blood is pushed into the aorta by the ventricle, aortic valve closes, ventricle undergoes diastole, and it is supposed to get filled from the atrium. But it is not only getting filled from atrium, whatever that it has pushed, all that blood is coming back to the heart. So that is the reason in the peripheral pulse, the pressure will steeply fall down. So the rapid downstroke is because of the diastolic runoff of the blood back into the left ventricle is responsible for this collapsing pulse, is what you need to remember. Then pulsus Bisferiens Two peaks in systole. Just before we discuss, what are the causes? HOCM, severe aortic regurgitation, AS plus AR, any of them can lead to two peaks during the systole. That's what you need to remember. Then pulsus parvus et tardus means small volume pulse, low cardiac output conditions, coarctation of aorta, severe aortic stenosis, they all lead to pulsus parvus. Jerky pulse, it is a small volume but collapsing. What do you have in aortic regurgitation? You have a large volume collapsing. That's called water hammer. But jerky means small volume collapsing. If there is a severe MR or any AR with LVF, that lead to small volume because of the LVF, volume is small and it is collapsing because of the AR. Right? Then pulses alternates. One strong beat, one weak beat, one strong beat, one weak beat. Where do you find? In LV failure or any arrhythmia. Then pulsus bigeminus. Pulsus bigeminus. Pulsus bigeminus means if the patient is taking digitalis, if there is a digitalis toxicity, then he will show ventricular premature complexes. That means the ventricular depolarization is not very strong. They are called VPCs, ventricular premature complexes. Whenever ventricular premature complex is there, right? So there is a decreased strength of the pulse. But after that, there is a compensatory pause, and then once more a strong beat will happen. So because of these variations, you get a pulsus bigeminus whenever VPCs are there because of digitalis toxicity is what you need to remember. Finally, doctor, before we call good night today, pulsus paradoxus. You should understand it. What is meant by pulsus paradoxus? Just before we discussed, what happens during inspiration? Inspiration will suck the blood because of the negative interthoracic pressure, right? And that will make increased volume on the right side of the heart. That will make the intraventricular septum to push into the left side. And because of that push, what happens? The left ventricle size become the left ventricle size become smaller. Because of that, the cardiac output decreases. Jaimin Sharma is asking, is this video or same like video broadcast again? Because I missed it. No, we are going to retain this video without removing from the YouTube, so you can always do the revision, don't worry. Right? Now, once more, tell me, doctor, what happens in pulsus paradoxus during inspiration? Negative interthoracic pressure sucks the blood on right side, and that makes intraventricular septum move towards left side and decreases the left ventricular volume and decreases the left ventricular cardiac output. So pulse become weaker during inspiration. Systolic BP will be typically falling by around 10 millimeters of mercury. But if you are having cardiac tamponade, constrictive pericarditis, acute asthma, SVC obstruction, in all these scenarios, this left ventricle becoming smaller because of the right ventricle bulged and pushed intraventricular septum into the left ventricle. That effect is there, no? Normally inspiratory effect of fall of the pressure that become more exaggerated, right? Because of the fluid outside the heart, this right ventricle, even if it has a little extra blood, it will push the interventricular septum significantly into the left ventricle and make the left ventricle get affected. The ability to affect the left ventricle by the right ventricle's increased volume, this phenomena become more significant if there is more fluid outside. Right? So, in all these conditions, the normally happening phenomena of a fall of inspiratory pressure become more exaggerated. How much exaggerated? It is so much exaggerated, so much fall is there that you can't feel the pulse at all at the time of inspiration. Right? Then why it is called Pulsus paradoxus? If it is an exaggeration of a normal inspiratory fall, why do you call Pulsus paradoxus? Is my question to all of you. Very simple. During inspiration, you can't feel the pulse, but still you are able to feel the apical beat. So this discrepancy is called as Pulsus paradoxus. Right? What is paradox about Pulsus paradoxus? You can't feel the pulse, but you can feel the apex beat. If there is a inspiratory fall of the pressure in the pulse, then you can't feel the pulse, but you can still feel the apical beat. Hence, it is called paradox. Tomorrow examiner will ask, what is Pulsus paradoxus? Pulsus paradoxus is exaggeration of a normal inspiratory fall of the pressure, systolic BP that happens, that became more fallen that you can't feel the pulse, but you can still feel the apical beat. When does it happen? It happens in cardiac tamponade, constitutive pericarditis, asthma, SVC obstruction, in all these scenarios. So this is the classical example, doctor. If you take the tracing of the pulse pressure, there is a fall of systolic pressure during inspiration, right? So typically this phenomena, if it becomes so exaggerated, you may not be able to even feel the pulse at all. You can't be able to even feel the pulse at all. That is called Pulsus paradoxus. So that brings to the end of our clinical cardiology examination of the pulse, what all the questions that you expect in the tomorrow's MBBS exam, and also what you need to examine on the bedside when you are examining the patient. I hope you all enjoyed. Tomorrow we will have a continuation of the clinical cardiology in about 8 to 10 hours. In about 8 to 10 hours, you will be getting most of the concepts in clinical cardiology bedside, what examiner is going to ask questions, what you are going to see. So we take another 10 hours clinical neurology, another 5 to 6 hours respiratory cases, and general medicine will take another 5-6 hours. So in about 25-30 hours, you are the pundits, experts, right, in the clinical medicine, which is required for cracking the MBBS final year practical exams. So thank you very much for joining this session, and also tell your classmates to join our Telegram group, MBBS exam going is our Telegram group. Good night.